Welcome to the OMM-Medicine's module on Acute Respiratory Distress Syndrome. Acute Respiratory Distress Syndrome, or ARDS for short, is an acute inflammatory insult to the lung, and it can have many different causes, as we'll go through on the next slide, but there are going to be some key characteristics to help you identify this condition clinically and on your boards. So the major characteristics of ARDS are all going to revolve around the lung and the insult that is going to happen to the lung, and therefore is going to have difficulty breathing. They'll have dyspnea, tachypnea, will have an increased oxygen requirement because we can't ventilate the lungs as well. And all of these features will largely be seen within 6 to 72 hours after the initial insult. Now, when you get a chest x-ray, which is going to be one of the major ways to diagnose ARDS, as we'll talk about shortly, you'll see diffuse infiltrates throughout both lung fields within 6 to 72 hours as well. Now, in any patient who is in acute respiratory distress, we will commonly obtain an ABG, and in patients who are in ARDS, you're going to see a respiratory alkalosis, and this is going to be because the patient's hyperventilating trying to catch their breath. And when we do this, we're going to blow off more CO2, and therefore we will have a respiratory alkalosis. Now, if you clinically suspect a patient has ARDS and you get an ABG, and it does not show respiratory alkalosis, but it shows respiratory acidosis on the other hand, this is a very scary finding because it means that the patient is losing their inherent respiratory drive and is therefore retaining CO2 and is therefore going to have an acidosis rather than an alkalosis. And this is a very scary finding and really should indicate the patient needs to be intubated immediately. Now, there are many different triggers for ARDS, as you can see on this slide. However, one of the most high yield for your boards is going to be pancreatitis. So in a patient who has pancreatitis and develops severe acute respiratory failure, we need to suspect that they may be having ARDS secondary to the pancreatitis. So how will we diagnose ARDS? Well, it's two components that are typically used, and that's going to be a clinical picture that is consistent with ARDS, as well as a chest x-ray. And remember that the chest x-ray is going to show diffuse bilateral infiltrates, typically between 6 to 72 hours after the initial insult. Now, if the chest x-ray or the clinical presentation is borderline and not truly diagnostic, then other options that can be used are bronchoalveolar lavage or a lung biopsy with evaluation of the histopathologic findings. And the most common one that will be seen when we look at it under a microscope from a lung biopsy in a patient with ARDS is going to be diffuse alveolar hemorrhage. Now, lung biopsy and bronchoalveolar lavage are typically not done in the diagnosis of ARDS. However, you should just be aware that these are options of diagnosis if a chest x-ray and the clinical picture are non-diagnostic. There is one classification called the Berlin definition of ARDS, and this is one way to try and objectively identify and diagnose ARDS, and the criteria are listed on this slide. So you would need the respiratory symptoms to develop within 1 week of that original insult. You would need the bilateral opacities on imaging that we previously discussed, and for these imaging findings to not be explained by an additional cause. You need the respiratory failure to not be able to be attributed to a cardiac or a volume change status. Therefore, we cannot assume that the patient is in respiratory distress because of a volume overloaded status, whether that be cardiac or non-cardiac in nature. And we need this to be confirmed by at least one objective test, which is typically going to be an echocardiogram. And finally, we need some evidence that there is impairment of oxygenation in the lung. And so this is how we will classify the mild, moderate, and severe ARDS scenarios, and that's all going to be based on the PaO2 and the FiO2, as well as the ventilator settings that the patient is going to require. Now, those are a bit out of scope for this talk. However, just know that we can further classify ARDS into mild, moderate, and severe based on these factors. And again, I just want to stress that typically the Berlin definition of ARDS is not typically used to diagnose ARDS. It's really going to be the chest x-ray and clinical picture. However, this is one criteria that can be used. So as we just discussed, in order to officially diagnose ARDS, we also need to rule out other common mimics of this condition, and the most common mimic that we need to rule out is going to be cardiogenic pulmonary edema. So essentially, we need to test the patient to see if they have any cardiac condition that would trigger pulmonary edema, and so we'll do this by getting a BMP, an echo. We'll listen to them clinically and see if they have any abnormal murmurs or heart sounds, such as an S3 or an S4. And then when we look at the imaging, we'll need to see if there's any curly B lines or pulmonary venous congestion or other signs that would indicate that the patient is having a cardiac cause of pulmonary edema. And another one is when we look at the imaging, if the patient has cardiomegaly, that would indicate that the cause is likely more cardiac in nature rather than ARDS, because in ARDS we should not have cardiomegaly. And finally, once we diagnose ARDS, how are we going to treat it? Well, it's largely going to be symptomatic and supportive. And so the major issue that we deal with in ARDS is going to be the respiratory compromise. So we first want to make sure that we secure the airway, whether that be supplemental oxygen, BiPAP, or intubation. If it's severe, we need to make sure that the patient remains hemodynamically stable, so ensuring that their blood pressure and heart rate are within our target goals. And then we also need to make sure that we are treating the underlying cause. So if the patient has ARDS secondary to pneumonia, then we would need to give them antibiotics to treat that pneumonia. Now there's some use for inhaled vasodilators and steroids. However, these are going to be more on a case-by-case basis rather than just administering them as part of the treatment regimen. And so we'll really need to look at our patient clinically before we administer either of these drugs. And that concludes this module on ARDS.